What I've seen over the last few years is a real evolution and development of the field with advances in surgical technology, equipment, techniques, and I've really been focused on a holmium laser lithotripsy technique called dusting, where my aim has been to do an efficient and low morbidity procedure to try and get a patient stone-free. So I have one case where I'd like to talk about where I had a gentleman who developed blood in the urine and some flank pain. The CT scan detected a stone that was around 1.2 centimeters in his left kidney, and there's also a smaller stone in the right kidney. So he was looking for treatment, and in fact he'd seen a urologist in another institution who had recommended that he have shockwave lithotripsy, but before he have shockwave lithotripsy, a stent be placed. He was unhappy with that option. Around 80% of patients with urethral stents have significant symptoms, urinary symptoms, flank pain, blood in the urine, and what we know is a good proportion of these patients, they don't go to work while they have a stent in place. So one of his main concerns was he really wanted to go to work the next day, and so could I do this procedure and leave him without a stent? If the stone is between, half a centimeter to up to a centimeter, I tell them the answer is often yes, I can often get away without a stent. If the stone is somewhere between 1 and 1.5 centimeters, I tell them the opposite. That's often I have to maybe, probably, highly likely put a stent. If it's much larger, they always get counsel very clearly that they're going to have a stent after this operation. So this patient who had a stone of 1.2 centimeter, I did explain that there's a high likelihood we will have to leave a stent, but we'd try our best. If I am gravitating towards a procedure where I don't want to leave a stent, I really have to try and do the procedure without a urethral access sheath. If I use a urethral access sheath, the patient will be stented after the operation. So in this scenario, the patient had a kidney stone that was around 1.2 centimeters in size, but it was somewhat narrow and thin, and so the volume wasn't as high as one would expect. The Hounsfield unit was around 1,100, so it wasn't as dense as a 1,300, 1,400 stones, which may not dust so well. So I felt in this particular case, I could begin the case without an access sheath and try to do a dusting technique where the patient would not need a stent. I have to say there's a couple of other things that I implement when I do a dusting approach. I do put patients on medication around 10 days before surgery, and I start them on tamsulosin, which is an alpha blocker, to relax the lower ureter. I use it for a couple of reasons. To promote my scope to get into their kidney easily, and I also feel that it leads to a lax, more loose ureter so that the fragments at the end of my procedure are more likely to drain. So that's a new thing that I've been doing recently. I have to caveat that there's not much strong evidence on this. We've seen some data on this where Dr. Clayman's group have found that to be the case, and they're currently doing a randomized controlled trial. When we get into the kidney, the first thing I do is I set things up. So in this particular case, the stone is in the renal pelvis, and what I never like to do is dust in the renal pelvis. So my next move is to move the stone from the renal pelvis into an upper pole location, because that's a really nice pocket to do a dusting technique. I tend to use a 200 micron fiber for most of my renal dusting cases. And I always teach the residents the 3 rules for that. It's better vision, there's a lower volume profile on the fiber, so it actually leads to smaller chips coming off, which is what I want with a dusting approach. And then the third V is versatility, because with the 200 fiber, if the fragment moves into a different part of the kidney, such as the lower pole, with a 200 fiber, you can actually get into the lower pole and deal with stones there. So the next thing we do is then we pick a laser setting. And then I usually pick a setting of around 0.3 joules and around 70 hertz. I use a long pulse mode, and then I do contact laser lithotripsy, where I dust the stone, systematically debulking the stone using strategies of chipping, dancing, and painting. So what I see is that the stone starts to shrink and debulk slowly in front of my eyes. Sometimes we'll find when we start with that setting, the stone may move around a lot. If that's the case, one has to then drop the repetition, so the hertz has to come down. So we may start at 70 hertz, but then we'll bring it down to 50 hertz or 40 hertz. So tweaking the pulse energy and the hertz is really important as you're starting to treat the stone with the laser. It starts to get smaller and smaller. And then at some point, it's inevitable that the stone, a large stone that's a 1.2 centimeter, starts to break up into smaller fragments that may be 3 to 4 to 5 millimeter in size. And there may be multiple of these fragments in a calyx in the upper pole. I then, at that point, I switch to a technique called non-contact laser lithotripsy, which commonly we all call the popcorn technique. And with that approach, what we've been doing is we've been using a particular setting of 0.5 joules and 80 hertz, where we intermittently fire in the middle of the calyx, not touching the wall of the calyx, not directly on the stone, just a little bit off the stone, and we do intermittent laser fires, and it's literally, as the name suggests, popcorn. Stones are moving around and they're sort of colliding with the laser fiber and they're breaking up into smaller pieces. So with that 200 fiber, I use that as a guide as I look at the fragments on endoscopic visualization, and I say, how does that fragment compare to my 200 micron fiber? And that's around 0.2 millimeter in size, so I use that as my reference guide. And if I look at a fragment and it looks similar to the fiber size in width, then I'm happy with the fragment size. So I try and get all my fragments less than 1 millimeter. If I see the fragments are sharp, they're jagged, I get concerned that they may not spontaneously pass in the next few weeks for that patient. Those are stones while I may have begun with a dusting technique, I may then start to retrieve with a basket. But in general, if I can get the fragments smooth and they're soft in nature, I'm very comfortable to leave 0.2, 0.4, 0.6 millimeter fragments. I cross my mind, well, should I leave a stent or should I not leave a stent? And so I'll tell you a little bit about my criteria for making that decision. So this patient had already been on tamsulosin, so I had felt that the ureter was somewhat lax as I entered the ureter with the flexible scope. When I withdrew the flexible scope into the ureter to assess the ureter on the way back out, I saw a lot of dust fragments along the ureter. That to me is a really good sign. It means that this kidney drains very well. So another important crucial factor is when I looked in the bladder, I already saw a ton of fragments that had already been evacuated. So this to me is a really important sign that that ureter will drain fragments and that the fragments are soft enough that they're passing down very well. So that's the moment that I made the decision, you know what, I don't think we need a stent here. He recovered very well, and in the PACU area I was speaking to him and I said, how much pain are you in? And he had no pain. And he achieved what he wanted to achieve from this operation, which is he wanted an operation that would get him back to work the next day. We got a CT scan, a low-dose CT scan for him at 4 weeks, and in fact that actually did show a few residual fragments in the upper pole. They were 1 millimeter in one area, another 1 millimeter in another area, very faint, so I knew that they were dust fragments. But what we then did is we repeated his scan 4 weeks later, and I'm pleased to report that he was stone-free at that stage. I currently image patients at 6 weeks, but 6 to 8 weeks it may be a reasonable time point. Laser lithotripsy for ureteroscopy has really evolved over the last 5 years, and I think being facile in both retrieval and dusting will allow us to tailor our treatment for the benefit of our patients.